This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on lumbar discectomy. Discectomy literally means remove part of the disc. Everybody at first says, well, how can you take out my disc? Don't I need it? Well, we're only taking off the broken part of the disc. So a herniated disc is part of the disc tears. The outer part of the disc is like a woven basket. It's the annulus. And you get a tear in that. It's kind of like a radial tire where the inside tears from the inside out and the piece flips out and it hits the nerve in the spinal canal, causes the nerve pain, sometimes numbness and weakness too, which we also call sciatica a lot of times. So a herniated disc is a tear in the disc, basically a broken piece of disc. A lot of times it's still attached. Sometimes it's totally broken off. It doesn't really matter. The point is part of it is protruding out into the spinal canal, hitting your nerve in your lumbar spine, causing pain, typically down the leg. And usually it hurts. Nerve pain just kills people. They can barely even see straight because the nerve pain is so bad. And a lot of times the medications don't really help. They kind of numb the pain. They kind of disassociate you from the pain, but they don't really treat it. People talk about it like taking up 30 to 50% of their brain, this gnawing pain going on. They can still work, they can still talk, they can still function, but they don't feel like themselves because they're really taken out of their life due to this annoying, killing pain. So a discectomy is to take out the herniated piece of disc, not the whole disc, just the part putting pressure on the nerve. And so people ask, well, how can you do that and still preserve stability? Well, part of it is that piece of disc is already broken. So you've already injured that disc. You can't go back from that. It's like partially tearing your hamstring or rupturing your Achilles tendon. No, the injury has happened. So we're not going to cure the injury to the biomechanical structure. But all we're going to do is take out this piece that's already broken that's putting pressure on the nerve. So there is a risk that this disc can herniate again, can develop degeneration, can be a source of pain and long-term disability. That's due to the primary injury, which is whatever you did to cause that disc to herniate. A lot of times, so forward flexion, rotation, picking something heavy up off the floor, well, that's the worst. That stresses the disc the most. But at the same time, these disc herniations happen all the time. It's one of the weak links of the human body is sometimes people just sneeze. Sometimes they wake up with them. Sometimes they bend over to brush their teeth. That's one of the things that is so disconcerting about these injuries is people say, I wasn't doing anything. I was just living my life. I was just turning on the TV. And I got this disc herniation. It makes them feel so vulnerable because they realize, wow, I can break down at any time and my life can change. I was normal. Now I'm in agony and I'm dying for help. So the discectomy surgery is just taking off the broken up piece of disc that's already broken. So the surgery does not decrease stability because that part of disc is already broken. There's about a 5 to 10% chance that that disc will develop severe degeneration as the years go on, be a real source of back pain, and need to have a fusion. But the studies have not shown that if you have the small discectomy surgery, that the risk of you needing a fusion is increased. So you've hurt the disc. There's a chance you're going to need a fusion because you're going to develop degeneration of the disc and pain from the disc in 5, 10, 20 years. It's not any more if you have the small discectomy surgery than if you don't, because the discectomy surgery just removes the part of the disc that's already broken, that's already not doing its job. It just takes the pressure off the nerve so that you can get back to your life. And basically the strategy is take the pressure off the nerve by doing the surgery, the discectomy, and then build up your core muscle strength. Get the muscle strong to keep stress off the disc to decrease the chance of needing a fusion and having back pain long term. And that's how we treat a lot of professional athletes. If they're not getting better non-operatively, we just go in and take the pressure off the nerve, get rid of their nerve pain, build up their core strength to get them back to their sport. It's the same way we treat everybody. So does everybody who gets a herniated disc and has nerve pain need to have a microdiscectomy or a lumbar discectomy? Well, no. In fact, 70% of people usually don't need surgery. They're able to be treated conservatively and non-operatively. And the way we treat people non-operatively is a combination of get rid of the inflammation and then build up your core strength, your muscle strength to get the stress off the disc. So there's two reasons people have pain when they have a disc herniation. There's the mass effect, this disc herniation actually pushing on the nerve, which hurts. The second component is the inflammation that goes along with it, these neurotoxic chemicals that irritate the nerve and the inflammation. So our treatment consists of really treating the inflammation. We do anti-inflammatory medication. We do oral steroids like prednisone, which knocks out the inflammation better than any other medication. We do epidurals, which is basically just prednisone, same stuff you take by mouth. We inject it in the back around the nerve to directly decrease the inflammation. Epidurals don't cure anything. They don't shrink the disc herniation, but they do decrease the inflammation to buy us some time to see if this nerve is going to accommodate and get by without having to have surgery. So first we knock out the inflammation because that's one component of the pain, and that usually takes 2 to 4 weeks to really get a sense as to can we get rid of the inflammation. And then whatever pain's left is generally more mass effect problem from this physical piece of disc pushing on the nerve. And usually the disc herniations are 5 or 10 millimeters, which is about 1/3 to 1/2 of an inch in size. But it's in a tight space, so there's not a lot of room for forgiveness. And part of that is it depends on where you get the herniation. The lower the herniation, down at L5S1, the bottom disc, the more room for forgiveness, the more likely people are going to be able to get over it non-operatively. The higher you go, up at L2-3, it gets pretty tight up there. So if you have a good size herniation, you're more likely to need surgery because there's less room for forgiveness. So the second component of the pain is this mass effect. And people say, well, if the mass is always going to be there, well, then I'm always going to have the pain. Shouldn't you just take it out? Well, that's not necessarily true. 15% of the time, your body will reabsorb the mass and the herniation will be gone. And that can take up to 15 months. So it can take over a year for that to happen, but it can resorb and dissolve on its own. It's like your body recognizes you're not using it anymore and dissolves it with enzymes. The other component is your body adjusts and it accommodates, where after a while, it's like somebody taps on you on the leg forever. And after a while, you just don't notice it anymore. So pain is an electric signal that goes from the nerve up to your brain that your brain perceives. Well, after a while, either the electric signals aren't being sent as much or your brain is just not paying as much attention to them. Either way, you're not having as much pain, so you don't need to have surgery. One other thing to note is your spinal fluid pulsates up against the disc herniation every time your heart beats. Every time your heart beats, this fluid in your spinal canal beats up against the disc herniation. It's kind of like water against a rock. You know, the waves crash up against the rock and they smooth it out. Well, every time your heart beats, the spinal fluid pulsates up against the disc herniation. It can smooth it out, make it a little bit smaller and not as pointed and not as likely to irritate the nerve. So that's another reason how your nerve can accommodate and adjust, and you may be able to get over a disc herniation without having to have surgery. So if somebody's not responding to conservative management, and sometimes it's very short, if it's only been a couple weeks and they have a significant weakness that will affect their job or their real ability to walk and to do basic things, we may go ahead and recommend surgery. Other times we give it up to 2 to 3 months. If somebody's slowly getting better, but then they plateau and they're not making progress, generally, if the person stops making progress on their own with just natural history and the functional deficit or the pain is too significant to live with, then we recommend surgery. And we usually give it about 2 to 3 months to see if this is going to happen, depending on a lot of factors. How much pain they're in, did they respond to the epidural, did they respond to the oral medications, have they responded to the physical therapy, and how much of a functional deficit is it, and are they getting better or not. Once they plateau, then we generally recommend surgery if the condition's unacceptable. And the surgery itself basically entails making a laminotomy. Most herniations, 90%, are right in the posterior lateral canal. They're in the spinal canal. Around 5 to 10% happen more off on the side, more of a far lateral or foraminal herniation, in which case we actually come in at like a 30-degree angle with an incision off on the side. We come in with a tube and the microscope. We take the herniation out through the foramen, which is kind of a specialized technique. But most herniations happen right in the middle of the canal. Therefore, the standard surgery done 95% of the time all over the world is to do a laminotomy, which means make a hole in the lamina. Now, making a hole in the lamina does not decrease stability because we're not doing a total laminectomy. A laminectomy means remove the whole arch in the back. That can decrease some rotational stability. A laminotomy, otomy means just make a hole in it. Ectomy means take the whole thing out. Laminotomy means just make a hole in the lamina. That allows us to get access to the spinal canal. We take out a slit of the ligamentum flavum, which is the ligament that goes between the bone and the nerve. Take a slit of that ligament out. Again, it gets us access to the nerve and the disc. And then the facet joint. If there's any overgrowth of the facet joint, any bone spurs or hypertrophy, if the joint has some degeneration to it and if it's overgrown, we'll shave down the overgrown side of the joint that is also contributing to the pressure on the nerve. And then basically we pick up the nerve, we see the nerve, and just lateral, just to the side and underneath the nerve is typically where the herniation is. Occasionally the herniation can be more inside the canal, more medial, in which case we may go on the other side of the nerve to get to it. And a lot of that we can determine on the MRI film. The MRIs are extremely accurate. And they're amazingly helpful. The fact that people did spine surgery before MRIs is kind of a miracle, and it kind of tells you why a lot of them didn't work and spine surgery got a bad reputation. With MRIs, the accuracy is so good that it can tell us really where is that herniation and where should we look for it. So we go usually just to the side and under the herniation. The herniation is kind of like a knuckle pushing up on the nerve. Generally, as we clear it off, we can pop a hole in the disc herniation and it'll start to squirt out. It's under pressure. So if we pop a hole in it, it allows it room to come into this space we've created, and it's usually under pressure. You kind of squeeze it, slightly like popping a zit for those who aren't faint of heart, but basically you squeeze it and it'll come out of that hole, and then we just pull it out. And we have these pituitaries, which are little biters that can pull on it. We have blunt hooks that kind of hook the substance and pull it out. The consistency of the herniation is typically like crab meat or gristle. So it's got some substance to it. I know on the internet it'll say it's like toothpaste or a jelly donut. Well, that's soft. Most herniations have some mass effect to it, and that's why they hurt so bad. And sometimes there's some watery component too. But our basic goal is to flatten out the back of the disc so there's no more pressure on the nerve. We just take out enough of the disc in order to flatten it out. Really the part that's protruding beyond the bone, which is in the spinal canal and putting pressure on the nerve, that's the part that's got to go. And whatever component is soft and fresh is the part that we take out, the part that comes out pretty easily in order to flatten it out. Now, we typically do not cut a big hole in the back of the disc because we want to preserve as much stability as possible. And a lot of times people will have bone spurs on the back of the vertebral body, and those bone spurs can put some pressure on the nerve. But if they're hard and they're stable and they're intact, we generally don't take them out. Because in order to take it out, we would have to take a chisel or a drill or some really bigger, sharper instruments to knock a big hole in the back of the disc. And that typically will cause more instability than it's worth. So typically if there's a bone spur or a hard component, we do not need to take it out because we don't want to cause the instability. And because we've done the laminotomy and made some room for the nerve, it gives some room for forgiveness where the nerve can drift back into that space we've created. So all we need to do is flatten out the disc as much as possible, take out the softer components in order to take the pressure off the nerve. We typically do not do anything to seal the disc. There has not been anything shown to be effective at really closing that hole in the disc. Using sutures can cause scarring. Using fibrin products, PRP, stem cells, all of these may cause an inflammatory reaction, which may cause more scarring, where the nerve can then scar to the back of the disc. We prefer to let the body just heal itself. If you give the body 4 to 8 weeks, typically that hole in the back of the disc, the annulus, will scar in and heal on its own. And so after surgery, you want to take it easy for the first 4 to 8 weeks and let that scar in and heal. But no substance being put in there has been shown to help the healing, to decrease scarring, or to make the back of the disc stronger. I mentioned earlier that typically if the herniation is right where they typically are, posterior laterally, 90 to 95% of the time, we go right in the midline, pull the muscle back and do the surgery through a blade and spike type of retractor. If it's off on the side, a foraminal herniation or a far lateral herniation, we use a tube for that surgery because we found the tube really prevents the muscles from creeping in, and we put the tube in under x-ray guidance, and then we lock it in place, and we found it just better holds the muscle out of the way. There's never been shown to be a difference between the result of a tube retractor versus a blade and spike retractor. They're both basically the same. They're both very minimally invasive, and they both basically do the same work on the spine, which is where it counts. We personally don't use a tube for the typical 90-95% of herniations. We did for a couple of years, and we just found it wasn't an advantage, that it doesn't really decrease any muscle dissection, and the results didn't really make a difference. And if anything, it limits your excursion and some of the angles you can get with your hand more so than the blade and spike. It doesn't really matter. It's more kind of surgeon's preference, and there really hasn't been shown to be a difference between the two. What you really want is a surgeon who's just conscientious, who's done a lot of cases, who has a good sense of, you know what, I want to preserve as much function as possible. I got to save these muscles as much as possible. And for us, obviously, treating professional athletes, any little muscle fiber we can save, we think helps and may matter. So we save as much as possible, and we do that on everybody. As long as the surgeon is conscientious and really trying to preserve function, do things minimally invasive, but at the same time, doing the job effectively. It doesn't do you any good to have a tiny little scar or no scar or something super minimally invasive if they don't get the job done, and you got to get the job done safely. Another component is, are you going to use a microscope or an endoscope? They have not been shown to make any difference. Some doctors don't use any type of magnification. I really prefer the microscope. You can still see three-dimensionally. It has great lighting. My assistant can help me. Usually the assistant can provide a third hand, which can help with certain retraction or just certain maneuvers. And so the microscope is really beneficial for an assistant and for the surgeon to be able to see. It blows things up, provides great lighting, is very easy to use, and you can still see three-dimensionally pretty well. The endoscope is very similar. It just, you look at a TV screen, and so the image is more two-dimensional than three-dimensional, and that's why I prefer the microscope. One other small component, which I've mentioned in a different podcast, is the laser. Everybody always asks, so are you going to use the laser on this? You're not going to make a scar, right? You're going to use the laser. And I've given a whole podcast on the laser's BS. It sounds amazing. People really want something that doesn't sound like surgery, but it sounds like a permanent fix, and the laser sounds like that. It doesn't work. Anyone I know who I think is using the laser, I've seen postoperative patients, they still have a scar. I think they're still basically doing the same surgery as everybody else. They're going in and taking out the disc herniation. And I don't know what they use the laser for. They just kind of turn it on one place or another. I don't think it has any functional benefit whatsoever. And so the typical surgery of discectomy takes about an hour, sometimes 45 minutes, sometimes 2 hours. You know, with any surgery, sometimes it takes longer because things are scarred down. The herniation's bigger. It's in two different places. We obviously don't even worry about the time. You take however much time it takes to get the job done and take the pressure off the nerve as safely as possible. Potential complications, there's always a risk of infection, a spinal fluid leak, nerve damage, which can be weakness, numbness, pain that you didn't have before the surgery, risk of any anesthetic, a stroke and heart attack and death. So there's always a risk with any surgery, but overall this is a very safe routine surgery that is probably the most common spine surgery done all over the world. The chance of getting a recurrent herniation, which means another herniation at this disc down the road in 3 months, 5 years, 10 years, is around 10%. If you get a recurrent herniation, a lot of times we can go in and do the same surgery again and take the pressure off the nerve again. If you get 3 herniations, then we start looking at doing a fusion because it means the disc is basically incompetent. It's herniated 3 times. It's just not holding it together. The fusion just gets rid of the whole disc itself and replaces it with bone, so the 2 bones grow together and fuse together. They never move again. They never hurt again. You'll never get a herniation again. So the fusion is the last resort, but it also works. It'll treat a disc that's incompetent. The recovery after discectomy, most times it's done as an outpatient. People go home the same day. I would plan on having somebody help you with just activities of daily life for the first 5 to 7 days. And you can walk around, get in and out of bed on your own, but you really want to take it easy. You don't want to bear down. You don't want to increase intra-abdominal pressure. So if you pick something heavy up off the floor where you hold your breath and you bear down and you strain, that's when you can squirt more disc out of the hole. So you really just want to take it easy, walk around, sit, stand, talk, basic things, and plan on no driving for 2 weeks. If you work, plan on taking 2 weeks off of work. It's still surgery. You should take 2 weeks off of work and relax and let your body heal. Most people can start working from home after 1 or 2 days, realistically. People can even get a driver, take Uber, go to work after a week. But really, if you can take 2 weeks off, that's the normal, sane thing to do, even though a lot of us don't usually choose that. But take 2 weeks off, give your body a break. I see people back 2 weeks after the surgery. We check their wound at that time. Then usually they can start to progress their activity. We start physical therapy at 4 weeks. And these are our guidelines, which aren't necessarily every doctor's. And so if you have surgery with somebody else, obviously listen to what they have to say. But these are the general guidelines we use. We start physical therapy generally 4 weeks after the surgery. We want that annulus to scar in and heal a bit first. Sometimes we wait till 6 weeks. But you start doing the physical therapy, and our whole program, which is in the Back Doctor app, entails stabilizing your back muscles to keep your spine in a neutral, pain-free position. So it's not about doing 1,000 sit-ups, because if you start to do a sit-up, you flex your spine, you can stress the disc more, and it may make you more prone to get a recurrent herniation early. So our program, you keep your spine in neutral where you're less likely to aggravate the disc, less likely to cause pain and cause more problems. So you learn to lock that spine in neutral and just simply move your legs and then move your arms and make sure you breathe the whole time or you're not bearing down and stressing. So we start locked in this neutral position, then you work your way up to more balance and coordination using a green ball, using hand weights, and endurance. The key to it is an endurance, where you can do a dead bug laying flat on your back for 3 to 5 to 7 minutes. Well, if you can hold that position, then you're protecting your spine, and you can go back to more regular activities and exercise, and you're less likely to provoke the pain and have future problems. Most people have pain from the surgery for 1 or 2 weeks. I would say at the 2-week appointment, 80% of my patients are not taking pain medication anymore, maybe a mild anti-inflammatory. So it's a pretty good surgery overall. There's always some unpredictability. Some people have a lot of pain. It takes a lot longer to heal. Sometimes they get this inflammation and irritation of the nerve and of the disc that can last for even a couple months. So there's always some unpredictability, but most people, 80%, no more pain medication by 2 weeks. So it's a pretty good surgery. Do the physical therapy. When can they return to all their sports and activities? And there's obviously a scale here. And usually the return is 3 to 6 months. And we know this from the professional athletes we've operated on. We published a paper where we operated on 85 professional athletes in every sport you can imagine, and 89% returned to their professional sport, which is obviously being able to go back and play basketball or football is pretty tough and demanding. But these are also 23-year-old pro athletes who have the amazing physical bodies and the desire, and they need to earn some money and everything else to go back to their job. So they're highly motivated, great athletes, but it's also highly competitive. If they're not at 100%, a good chance someone else is going to take their job. So you can extrapolate those results to normal people, and that's what we basically found. It's generally 3 to 6 months to get back to your activities. The average return to pro sports for us was 5 months, and that's about right. We had 50% of pro athletes make it back at 3 months. So half are back at 3 months playing in a game, but the average return is about 5 months, and generally I say 3 to 6. And in that same discussion, if you really want to be cautious and conservative and give your body the best chance to heal and never have a recurrent herniation and never have to have surgery again, I'd give yourself 6 months. And our program, our back stabilization program in the Back Doctor, is a 5-level program. You start at level 1, 5 is the hardest. And that quantitative program allows us to gradually return people back to activities based on how strong their core is. So when they get to level 2, we know their back muscles and abdominal muscles are strong enough to protect the spine. We let them go back to an elliptical, swimming, and biking. When they get to level 3 is when you can start to jog, do more rotational activities. And for the athletes, that's when they can start getting back to their sport. They can start shooting, running, swinging, skating, and they can get back to more of their sport-specific exercises and lifting weights. Level 4, before they can really practice with their team and be cleared for the weight room. And level 5, before they go back to their professional sport. Most common people, recreational athletes, we want at a level 3 before they go back to their sport. So the most conservative estimate is if you're at level 3 and you're 6 months out from the surgery, well, that's an extremely safe window that you can go back and pretty much do everything. If you want to be super conservative, wait till a year. I'm 46 years old now, and a lot of injuries I've had, well, they take a lot longer to heal. So if I was in my 40s or 50s and I had a discectomy, I'd give my body a year before I really went back and did anything hardcore. By 6 months, if I was at level 3 and not having any pain, I'd still ski, swim, run, do all the basic things. But playing basketball with my kids in the backyard where they're starting to get too big and starting to hurt me, I'd probably wait till a year. That's the safest way to give your body time to heal. One of the hardest things about treating professional athletes is we don't really have time. Time is not a luxury. These guys got to get back, or women have to get back to play their sport. That's how they make their money. That's their job. That's their passion. That's the whole purpose. And so they can go back at 3 to 6 months because it makes a big difference, and they're safe to go back at that time. But if that's not your job and your life and income and everything is not dependent on this, give your body a year to recover. Yeah, that's even better. So I mentioned at the beginning that around 70% of people with disc herniations don't need to have surgery. About 30% go on to have surgery, and the results are good. Probably 85 to 90% of people are really helped by the surgery and are happy they did it. And our results show that people's pain generally averages a 7 out of 10 before the surgery and averages a 2 out of 10 after the surgery. So you go from a 7 to a 2, which is obviously a good reduction in pain, but a 2 out of 10 post-surgery means most people average around a 2 out of 10. Now, some are to 0, some are to 4. The average is a 2. Why? Well, because we just took that broken piece of disc out. We didn't cure the whole disc. That disc has been injured. You may have some back pain from the disc. You may still have some residual nerve irritability, either just from permanent damage from before the surgery, the injury that occurred to the nerve, or during the surgery. There may be some scar tissue or other issues and inflammation from the surgery. But overall, from a 7 to a 2 is a good reduction, and it helps most people, and most people are very happy with this surgery. But there are no guarantees in life, and so obviously you always want to consult with your surgeon and get a couple opinions if needed, and really be comfortable that you have a proper understanding of what the situation is, what are the risks, what are the potential benefits, and is it really worth doing. So that concludes our podcast for today. If we can be of any help, come find us at watkinsspine.com or the Back Doctor app, which is free in the App Store, and I wish you the best of luck in the future.